question. All right. The definition of periprosthetic joint infection, there's lots of different classification or criteria, but the one that I think is the most up-to-date is from the Musculoskeletal Infection Society, and that's a picture of Gurka, the guy from the Endo Clinic in Germany, and Javad Parvizi, and it's major and minor criteria. And the major criteria are at least one of 2 positive cultures of the same organism, or a sinus tract with evidence of communication to the joint or visualization of the prosthesis. That is a definition of PJI. And the minor criteria are from preoperative diagnostic tests on the blood, the serum, and the synovial fluid. And you can see them there, each getting a score. So elevated CRP or D-dimers in the serum, or elevated ESR in the serum, getting a score of 2 or 1. And then the synovial fluid, which should be analyzed pre-op with elevated synovial white blood count or leukocyte esterase, positive alpha defensin, elevated synovial polymorphin nuclear percentage, or elevated synovial CRP. And if you get any of those things, add up the score, and if more than 6, it's infected. 2 to 5 is possible infection, and 0 to 1 is not infected. And then intraoperative diagnosis, if your preoperative tests are inconclusive, or you get a dry tap, which often happens in the hip in our setting, you then will get a score for positive histology, positive purulence, or a single positive culture from surgery. Okay, just a little brief thing on the epidemiology. It's obviously a massive problem with hundreds of thousands of hips and knee replacements performed in the US annually, and a large number, 27,000 revisions for PJI performed in 2013. In 1979, John Charnley, who's the father of hip replacement surgery, said that joint sepsis will be the major hurdle in our way in the future. Just to highlight the cost of this, and we've just recently had a patient in with a 2-stage revision, basically lay in hospital for like 2 months on intravenous antibiotics. Obviously the long hospital stay, ended up having 3 procedures, a first stage removal, washout a week later, and then a second stage 6 weeks after that. And pretty much the first and the second stage ended up being 3 hours, I think, in theatre, and the washout obviously a bit shorter, but you can just see how the bill will rack up. Just to note that PJI is an independent predictor of mortality, associated with a 4 times increased odds of 1-year mortality compared to an aseptic revision. So it is got some worse 5-year survivorship than some cancers. You either get it at the time of surgery, direct seeding, or from hematogenous spread at a later stage. It is often associated with a biofilm becoming extremely difficult to eradicate. And you just need to understand that there is this entity of culture negative PJI. You need to know a little bit about biofilm and biofilm formation. The bacterial concentration needed for infection is 100,000 times lower in the presence of a foreign body or metal. Interestingly, the type of metal does influence the adherence of bacteria, and also the microstructure of the metal. So trabecular metal, or 3D printed metal that is often used in hip replacement surgery on uncemented components, is more resistant to bacterial biofilm formation. It basically occurs when the individual bacteria organize into a community and behave like a single organism with these kind of 4 stages of attachment, expansion, maturation, and then resistance to any penetration by anything. This is also a fairly recent review article from 2020 highlighting the 20 common errors in the diagnosis and treatment of periprosthetic joint infection. So I thought we better just highlight these here. Delayed diagnosis was seen to be one of the biggest errors. The only solution, I think, for us and the policy that we've taken in Groote and on the secondary level hospitals is that we must, don't hesitate trying to, think, always just be highly suspicious of periprosthetic or PJR, and so that we can get the patient preferably to the right place, but I think it's not going to be really feasible for us to do all the PJIs at Groote, but certainly it's very useful to try and get hold of Tom or myself or Maritz if these patients sort of come up in your radar from the peripheral areas, and then the diagnosis from basically will involve surgery ASAP. Mistake is swab samples rather than tissue samples. Mistake is using the CRP to rule out infection. Let's use that Hamad typing, just mute. No, he is muted. Disregarding distant sources as a source of infection, and incomplete synovial fluid analysis, inadequate number of specimens, so we recommend a minimum of 3, but 3 to 5 is good. Antibiotic treatment without any surgery. I'll put there reserve for frail. We've certainly got a handful of patients who we have decided just to suppress rather with antibiotics rather than undergo any surgery, and I think these patients need to be decided on an individual basis. Okay, 2 weeks of no antibiotics prior to biopsy is useful. Obviously, failure to individualize treatment. We've got all these protocols and guidelines, but you need to obviously treat every patient and every organism individually. Arthroscopic lavage is thought to be a mistake, not good enough. Oh, sorry. Okay, insufficient debridement or incomplete exchange. Once again, this has to be weighed up, because if you have a very well fixed femoral component in a hip replacement, for example, you may end up destroying the femur to remove it, and you have to kind of sometimes weigh up whether it's better to, perhaps if you think you've identified the source of infection being a biofilm on the acetabular component, and you got a femoral component where there's just a small trunnion that's exposed, you could argue that the balance of probabilities are in favor of just exchanging the acetabular component or doing a one stage and then covering the exposed femoral component with some antibiotic cement as a spacer, and then going back and just replacing a head onto the existing femoral component. But yeah, there's always a risk that there are some bacteria that are hiding down on the femoral component. But the bottom line is you really have to do a thorough debridement and remove all components to try and get close to 100% cure rate. But even then, a 2-stage with removal of everything is, has only up to sort of 95% cure rate. Avoid high pressure pulse lavage and no antibiotic holidays in a 2-stage procedure. The Maritz quite likes the European Bone and Joint Infection Society definition and practical guide. This is published in the BJJ last year, so it's also quite new. This is the table that is in that article, and they divide it into also clinical and blood workup with clinical features, and then other types of modalities such as the imaging and the microbiology. And then they have 3 columns. On the left, the infection is unlikely, where all findings are negative. The middle is infection is likely, with 2 positive findings. And then on the right-hand side, infection is confirmed with any of those positive findings. They're quite similar to the Musculoskeletal Society criteria. So let's just go through them quickly. Clinical features. So infection unlikely if there's clear alternative reason for implant dysfunction, e.g. a fracture or implant breakage or malposition or tumor. Infection likely if there are radiological signs of loosening within the first 5 years after implantation. Aseptic loosening from polyethylene wear is usually after 10 years. Unlikely if there is, or infection likely if there's previous wound healing problems. This is quite a crucial thing to get from the history, or a history of recent fever or bacteremia, and obviously purulence around the prosthesis. And then it would be confirmed like if there's a sinus tract with evidence of communication to the joint or visualization of the prosthesis. So that would be like one of the major criteria. A CRP, serum CRP greater than 10 is infection likely. Okay, but obviously for infection to be likely, you need 2 positive findings. So 2 out of any of those features in the column. And then the synovial fluid cytological analysis is really looking at the leukocyte count, white cell count, and the polymorph percentage in the synovial fluid. And you can just see the various values there: less than 1500, more than 1500, or more than 3000. And then the polymorph percentage, less than 65, more than 65, more than 80. So 80% is, and 3000 cells per microliter are the synovial absolutes for infection being confirmed. Alpha-defensin is a biomarker produced by the leukocytes. I'm not sure which cell line, I can't remember which cell line makes it, but basically it is, if you pick up alpha-defensin protein in the synovial fluid, it is confirmatory that there are bacteria in that fluid, and this is the body or the cellular response to the bacteria as this protein. It is, they don't mention leukocyte esterase here, so that Jimmy Kauta did a little study with that, and then that has shown to have some correlation to alpha-defensin. The alpha-defensin that we have available is very expensive. It's it's like a dipstick, which you need to have clear synovial fluid aspirate on. It can't be contaminated by blood, and it is, I think Zimmer supplies it, and it is a qualitative test, like a pregnancy test. So you drop the bit of synovial fluid on, and if it reaches the sufficient threshold, it will then put a little line on the pad to say that it's positive. It is not as good as a quantitative measure in the laboratory, but we don't. It's not. I don't think that is offered in South Africa anyway. But when they do the research on it, they are able to quantify the value of alpha, or the amount of alpha defensin, and obviously that's more accurate or more reliable. Obviously, the microbiology then is with the culturing. So if you have positive culture, a single positive culture, or more than one colony forming unit per milliliter of any organism, then that's likely infection. But two positive samples with the same microorganism, or more than 50 colony forming units per mil of any organism, then is a confirmed infection. And then histology, basically the only thing that's going to give infection confirmed is the presence of more than 5 neutrophils in more than 5 high power fields, or the presence of visible microorganisms. Nuclear imaging is not used much in our setting, although it is relatively at Groote it's readily available and relatively cheap compared to in private. But you can see there isn't really a major criteria for nuclear imaging. It can be quite useful, but also not in the early stages post-surgery. Okay, risk factors for PJI: active infection elsewhere, blood transfusions, patient factors including diabetes, malnutrition, smoking, immune compromising diseases, drug use, nasal carriage of Staph aureus. And then obviously to prevent it, we can do things to optimize the host regarding the various factors that we've just mentioned in the previous slide. Decolonize the patient from MRSA using chlorhexidine or mupirocin in the nose. Intraoperatively, there's prophylactic antibiotics, and we've just recently moved to the single dose Kefsol for our primary joints, and paying attention to skin preparation, ventilation, and lavage intraoperatively, as well as the minimization of theatre traffic. And then I've put here question mark about prosthesis choice. There is some interesting work, certainly up until end of last year, that was being done on silver coating and nanotechnology on implants to try and resist bacteria or kill bacteria or resist biofilm formation. So maybe Hamad will find us some interesting stuff relating to that prosthesis choice. And then obviously post-op, dressings and drains, and we have got we pretty much stopped using drains, I think, across all the low limb arthroplasty teams, and our dressing policy is quite strict in that we don't like the nurses opening dressings and changing dressings unless they're obviously soaked. But if it's less than 50% blood soak on the dressings, we just waterproof them, or just put a clean dressing on top of the other dressing, so that we're only exposing the wound to the outside at the 2-week mark. Pretty much the treatment for PJIs is DARE, 2-stage exchange, which is still the gold standard, and certainly what we're using. At 1-stage exchanges, I think, are going to have to become the norm, because it's just I think the 2-stage exchange is just too costly. And then obviously just antibiotic suppression. The DARE, debridement and implant retention, it depends on the onset of the infection. The longer it has been there, the biofilm starts to, or organisms start to take hold on the prosthesis after a day or so. but a mature biofilm can take up to 3 weeks to establish itself. And so, you know, the kind of number that we often bandy around is if the infection is less than 3 weeks. So if the patient is presenting with an early post-operative infection within 3 weeks, you know, we can have high rates of success with debridement and implant retention, just exchanging them easily exchangeable modular components. So in an uncemented hip, it would be the liner and the head. The success depends on the organism involved. Obviously, more virulent organisms, more resistant organisms are going to be harder to eradicate. The host's immune function and health is important. And I would say also probably even more important is then the surgical procedure. It shouldn't really be something that is done by a junior or an inexperienced surgeon. It often takes as long as a primary hip replacement to do a debridement and implant retention. You don't really have to spend a lot of time, you know, washing, cleaning, debriding any obvious necrotic tissue, trying to remove any macroscopic infective tissue, using things like the VersaJet, you know, but any kind of surgical removal. Yeah. Two-stage exchange is our go-to gold standard. I think still probably the main treatment that's happening at Groote Schuur. You know, the interval between the removal, which is the first stage, and the reimplantation can be anything from 6 weeks to 6 months. There is some controversy about the antibiotic holiday or having a period without antibiotics, but certainly if you're wanting to optimize culture of organisms from a surgical from surgical specimens, you have a markedly decreased yield if the patient has had antibiotics within 2 weeks. So a good time, obviously, you know, you want to have the patient mustn't get prophylactic antibiotics at the start of theatre when you're going in to try and identify organisms. But if you've got some doubt as to whether the surgery has, or if there's some organisms remaining, you know, then if you know, obviously if they obviously got signs of infection, then you would, you know, it doesn't matter what antibiotics they've been on, because you're going to probably be culturing a resistant organism anyway. But if there's some doubt if they are infected, then it's probably a good idea to make sure they're off antibiotics for at least 2 weeks, so that when you go into surgery, you're going to have a higher chance of identifying the organism and not end up with one of these culture negative PJIs. The one-stage exchanges are most popular in units that have dedicated septic revision teams, who are obviously working very closely with the microbiology, the physicians, and you know, the key is really trying to make sure that you have a sensitive organism. It is basically 2 separate operations that are occurring on one day. So you would still remove the infected implants at a you have to have the diagnosis. So you have to have the organism diagnosed from hardware removal biopsies. So it would still, although it's a one-stage operation, or it's 2 operations on one day, you have to have some kind of procedure, you know, preceding, at least a week before, where you've identified the organisms. So either an aspiration where you've cultured organisms, or a biopsy with 5 specimens and culturing 2 specimens with the exact same organism, because you need to implant or put any antibiotic, local antibiotics in the cement that are directed at the organisms concerned. And then you'll remove the implants in the first operation, stitch up, re-drape, re-clean with all new instruments, and then go and do your do the second stage or the reimplantation as a separate operation. It's just under the same anesthetic. So it's a one stage, but it really is still two full separate operations just occurring on the one day or under the one anesthetic. And then, as I said earlier, suppression, antibiotic suppression of chronic infections. We've got a handful of patients in our unit who have what can only be, I can only think is a focal area of biofilm on a piece of the implant that has found a little sinus tract, out to the skin, and that is intermittently draining. The patient does not have a loose implant. They're basically pain-free, and they're pretty much just bothered by this discharging sinus that occurs periodically, and they tend to dry up with the use of antibiotics. So there's obviously some kind of almost symbiotic relationship with the sensitive organism that's kind of just made its home on the prosthesis and is not causing any major reaction. The patient's not systemically unwell, and the sort of two-stage or even a one stage, but removal of well-fixed implants is going to possibly have more morbidity than just keeping the patients on intermittent antibiotics and dressings. And these patients or the few that we have kicking around, I guess there is a risk of those organisms becoming now resistant, and then not being able to be suppressed with intermittent courses of antibiotics. But I guess we're just weighing that up against the morbidity associated with removing it. So it's really a reserve for, I think, very elderly, frail patients who aren't able to tolerate surgery, or where you think that the risk of surgery is just going to be, outweigh the benefits. The various molecular biomarkers of infection. I think you probably just need to know that there are many new modern assays and analyses that are occurring, looking at the various cytokines, the interleukins, tumor necrosis factor, various adhesion molecules, growth factors, other than our usual CRP and ESR. I don't think there's, practically in our acroscure, certainly we aren't using a lot of these. Even the alpha defensin is, even in private, is not being used a huge amount. And then I think last but not least is the phages. So phage therapy is very exciting, and is I think there's some research going on with phages at UCT.